Hello, hi, good afternoon. It's Sunday afternoon and this is my 4th Instagram Live that I'm recording for you. The other 3 have been uploaded onto my website and also on my Instagram feed. So before I get started, I really want to say that I'm a GP and a menopause specialist. I work in Stratford-upon-Avon. Well, at the moment I'm working from home. I'm not a cancer specialist at all. In fact, interestingly, I was going to specialise in oncology before I went into general medicine, but I'm doing this today to really just give an overview, and it's quite difficult to give individualised information. So all I really want to say is I'm hoping what I'm going to tell you in the next hour is really food for thought. It might be a trigger to start a conversation with your oncologist, with your GP, with a menopause specialist. I can't give individualised advice. So I'm really just saying this because I don't want to put your hopes up, but I also don't want to frighten you either, because this is such a massive topic. So I hope over the next hour you'll learn some interesting facts, and I've been overwhelmed with questions from lots of women, and the reason that I've decided to do this today is because I see and speak to a lot of women who've had cancer in the past, and a lot of them are struggling with the menopause and they're not getting the right help, advice, attention, information, treatment. And actually, I'll just tell you as an aside, when I started my clinic, I saw a young girl. I'd only been doing my clinic for a few weeks. She's 22 years old, and she came all the way down from Scotland, and she came to see me because she'd had to give up her university degree because she had an early menopause. And when I asked her about her early menopause, she had it because she'd had leukemia, a blood cancer, diagnosed when she was 19. Because she'd had drugs, chemotherapy for the leukemia, she'd had an early menopause, and then she actually developed a clot afterwards. So she used to be on the contraceptive pill that had been stopped, and she was told she couldn't ever take hormones. This was a 22-year-old girl that had her whole life ahead of her. She was in remission from her cancer, yet she had so many menopausal symptoms. So she'd come down from Scotland. Hours it had taken her to come down and see me, and I was delighted that I could reassure her and give her HRT, and since then her life has been transformed. But for every one woman like her I see in my clinic, I'm conscious there are thousands, if not millions, worldwide who are given inaccurate information, and this worries and saddens me. So I can see already there's a lot of questions coming up. I've got 3 of my amazing colleagues who are going to be answering some questions. So look out for Zoe, who's my from Manchester, Sarah Molly Ball, and also Rebecca Lewis, who will come up as Rebecca Rawle, and they'll try and answer some questions for you. So if you've listened to my Instagram lives before, if you haven't, then it would be worth listening, because I do talk a lot about the menopause. But just to overview, really, the menopause occurs because our ovaries run out of eggs. And this is either a natural process for a lot of us, but it can be enforced. And for a lot of women who have cancer, it is enforced, either because they have a type of cancer in their gynae reproductive organs that means that they have to have an operation to remove their ovaries, or even just remove their womb, and having a hysterectomy can still increase the risk of an early menopause. A lot of women who've had cancer have to receive drugs such as chemotherapy, or they receive radiotherapy, especially if they have a pelvic cancer in their pelvic region. So having chemotherapy and or radiotherapy can bring about an early menopause. For some women it's temporary because it just lasts when you're having treatment, but for a lot of women it's irreversible damage. And quite rightly so, a lot of specialists will talk to women about fertility options if they're young and going to have damaging treatment to their ovaries. But often the menopause gets neglected because people just think it's just when our periods stop. And when you're faced with a cancer diagnosis, the last thing you're going to be thinking about is your menopause. But actually, the menopause, obviously, it's when your periods stop, but it's associated with lots of symptoms such as fatigue, memory loss, low motivation, anxiety, reduced libido, urinary tract infections, vaginal dryness, headaches, feeling low self-esteem. And all these symptoms, lots of people think, oh, that's just because she's had cancer. It's because she's had chemotherapy. It's because she's had an operation. But actually, a lot of it is due to the reduced hormone levels that are occurring because of an early menopause. And then some women have what's called a medical menopause. So it's brought on by drugs. So commonly this is if someone's had an estrogen receptor positive cancer, usually a breast cancer, and they have treatments such as an aromatase inhibitor. Examples are letrozole or anastrozole, which block the effects of estrogen on the body, and so they are forced into a menopause. Some women will take tamoxifen, which is a SERM it's called. It's a selective estrogen receptor modulator. Bit of a mouthful, but basically it means in a lot of our tissues it will block the effects of estrogen, again causing a menopause. So it's worth thinking about that. If you have had some of these treatments, are you menopausal as opposed to are your symptoms related to your cancer treatment, for example? A lot of women find their symptoms can last for several years. The average length of duration of symptoms is about 7 years, but some people it's longer. So there are symptoms related to the menopause, but also there are health risks, which I have spoken at length about before. But if women have low estrogen levels for long periods of time, they have an increased risk of diseases such as osteoporosis, heart disease, diabetes, dementia. And the reason I say this is because this is when you look at how to manage your menopause, you're looking at ways to reduce symptoms, but you also need to look at ways to improve your future health as well. So a lot of people are asking, well, how do I make a diagnosis? I've had my ovaries removed, or I've know that I'm menopausal, but I keep going to my doctor and they say I'm too young. Well, actually, if you're under the age of 40, a blood test might be helpful. It's not always helpful because hormone levels can still change even if you've gone through the menopause. And if you're over 40, then hormone blood tests are less likely. If you're young, and young women have early menopause even if they've not had cancer, or women who are young and have had cancer might have an early menopause for other reasons. And there are blood tests we often do, and I spoke about this a couple of weeks ago. If you're young and you have had an early menopause under the age of 45, then you should be asking for a bone density scan as well, and that should be available on the NHS, just to see what your bone density is, because we know that the bone density reduces with a menopause. So that's just a bit of a brief overview. So then we need to look at treatment for the menopause, and clearly there are lots of treatments. It's not just one treatment either. Firstly, I want to just talk about general treatment that we should all have. So we should all be looking at ways of improving our bone health, our heart health, our brain health. And so by this, it's the hardest part actually. It's looking at our diet and our lifestyle. And that's very difficult, especially if you're plunged into the menopause and you've got a low mood, reduced motivation, joint pains, muscle aches, fatigue. But it really does pay dividends to look at your diet, trying to cut out processed food. Some people find that spicy food can make hot flushes and sweats worse. The sugar is hidden everywhere, so if you can cook from scratch, it is really worth it. And everyone's busy. I'm very busy. I've got 3 children, but I cook a lot for the freezer, and it's really important to try and eat as healthily as you can. We also know that having a good diet will help, especially if it's got good calcium in our diets. Then that helps with our bones, but also a good Mediterranean style diet can help reduce risk of heart disease. And also there's some great evidence showing about brain foods as well to improve our brain function. So it's worth spending some really good, valuable time looking at your diet and maybe your family's diet as well, but ways of improving it. Then exercise is really important for all of us, but you have to find a type of exercise that suits you. There's no point trying to encourage people to run marathons if they don't even walk up the stairs without having pain in their joints. So it's just working out the right exercise for you, but anything that gets your heart rate going, ideally 3 times a week is good. As a lot of you know, I personally do yoga, and I find it's very good physically, but also mentally it's really good for me, and it just calms me down a little bit. It keeps me physically strong, but it also helps my core. And at the end I meditate, which I find immensely important. So, looking at ways of our well-being, so meditation, looking at sleep. And sleep is so difficult for a lot of women who are menopausal. They find that their sleep becomes interrupted, or they're waking at crazy hours, they can't get back to sleep, and that compounds the fatigue that is a very common symptom. Some people find changing their bedclothes, bed linen, some people use a woolen duvet, different cotton sheets, there's all sorts, but it depends on whether you're woken up by the night sweats or just woken up. And I have done a podcast about sleep recently, which might be worth listening to, because for all of us it's really important to get enough sleep, because without sleep it has a really big impact on our health and well-being going forwards. So just taking some time to think about your menopause not just being symptoms, but about your future health and how you can improve your future health and well-being. And this is regardless of whether you take HRT or not. We all need to look at our health and well-being. And women that have had cancer are no different. They have to look at their well-being too. And it's very difficult sometimes when your motivation is low and you're feeling tired, then to actually think more about your future and how you're going to plan your life can be difficult. But certainly just some simple tips can really make a difference for a lot of people. So if you look at, I'm going to just spend a few minutes now talking about HRT. Now, HRT is 3 letters, as I've already said, hormone replacement therapy. There are different types, there are different doses. Now, some women shouldn't be taking HRT first line for their menopause, but a lot of women can. So I'm going to spend a few minutes talking about those women who can, without any controversy whatsoever, take HRT. And then I'm going to spend some time talking about treatment options and about whether HRT can be given for other women. So I'm just going to split it up, so I hope that helps. So there are lots of cancers that are not related to hormones at all. And obviously there are a lot of women who have experienced cancer or who will experience cancer. Some will be taking HRT and have been told to come off it. Some may have had cancer when they're in their 20s, 30s, like this young girl who had leukemia, and then develop menopause because of their treatment, or just because they get into their late 40s, early 50s and have a natural menopause. And I have had a huge number of messages from women who have had cancers in the past and being told they can't have HRT for the wrong reasons. So if you look at other cancers, so any cancer that isn't estrogen receptor positive, usually you can still take HRT. So cancers such as thyroid cancer, melanoma, skin cancers. Somebody messaged me about bowel cancer and was told they couldn't have it because it had spread to their lungs. This is incorrect. You can still have HRT if you have bowel cancer. If you've had a cancer in your cervix, even if it's been quite extensive, you can still safely take HRT. If you've had cancer in your vulva or vagina, you can still take HRT. Cancer of the ovaries, women can still usually take HRT. There's some types of ovarian cancer that do respond to estrogen. So these are usually a granulosa or a serous cancer. So you need to just check with your oncologist what type of cancer it was. But this can be confusing because in the insert with HRT, it will say that there's an increased risk of ovarian cancer in women who take HRT. Now this was done looking at an observational study, so this was a questionnaire study, it wasn't a randomised control study, and actually this has never been shown. The big study, randomised controlled studies that have been done actually showed there were less ovarian cancers in women who took HRT. So taking HRT does not increase the risk of ovarian cancer. Sadly, the information with HRT packaging is incorrect, and on various websites, even some cancer websites, is incorrect. There is no increased risk of ovarian cancer in women who take HRT. And for most women who have had ovarian cancer in the past can still safely take HRT. Now with womb cancer, so uterine cancer, which is very common, most types are not estrogen dependent, and thankfully most types are early. They're picked up at an early stage, and women have a hysterectomy often without any other treatment such as chemotherapy. If you've had an early type of uterine cancer, then you should usually be fine to start taking HRT. And most other grades and stages of uterine cancer, women can still take HRT. There is a type of uterine cancer called a uterine sarcoma, which is usually estrogen receptor sort of positive. So those women shouldn't take HRT in the first instance. More and more the oncologists are testing cancers for estrogen, and if you have had any type of cancer, it's worth just checking with your cancer specialist if they've been tested, if the cells were tested to be responsible or responsive to estrogen. But actually a lot more women have been sadly told they can't have HRT because they've had cancer in the past. And in fact, I saw someone remotely, because we're doing video consultations in my clinic last week, who'd had quite an unusual cancer. It's a rhabdomyosarcoma, bit of a mouthful, of her arm when she was 24. And she'd had half her arm amputated because of the cancer when she was 24. She came to see me in my clinic a couple of years ago because she was 51, average age of the menopause, experiencing menopausal symptoms, and she was incorrectly told she couldn't take HRT. So I saw her a couple of years ago, gave her HRT, and she felt amazing. She was back working, she's a medical secretary, her life really transformed, and then her new GP told her she'd had cancer, she couldn't go on HRT. So she came back as a review last week and was distraught because all her symptoms had come back. So she can clearly take HRT. Women who have had cancer need to live great lives. And so for a lot of women, I hope this will reassure them that they can actually take HRT. Now, before I start talking about breast cancer, there's a lot of women who have a family history of breast cancer. And not all people who have a family history of breast cancer have an increased risk themselves. It depends which family member has breast cancer. So it's usually, if you have a first degree relative, then it's quoted as about a double increased risk of you yourself developing breast cancer. So a first degree is like your sister or your mother. If you have other relatives, it might just be because you've got a big family, but it's worth just going through with your doctor to see if that increases your risk. There are some genetic conditions, you might have heard of the BRCA genes, so there's BRCA1, BRCA2. If they're positive, you're more likely then to have breast cancer, but also cancer of the ovary as well. So a lot of women have a family history of breast cancer, they're menopausal themselves, they've never had a history of cancer, but they're wanting to explore the option of taking HRT. And women can still take HRT if they have a family history of breast cancer. So there isn't any evidence that taking HRT increases their risk further. So I've already said some of these women will have an increased risk of breast cancer, but taking HRT isn't going to increase this risk more. And in fact, some studies have shown that taking HRT in women who have a BRCA gene actually have a lower risk of breast cancer. So it's interesting, isn't it? It's not all about hormones. A lot of women who have BRCA1, BRCA2 gene actually have a oophorectomy, so they have their ovaries removed because of this increased risk of ovarian cancer. And as you can imagine, if you have your ovaries removed, you are plunged into a surgical menopause, which I'm going to talk about next week. But it's a very harsh, unnatural type of menopause. Because these women have an increased risk of breast cancer, I see a lot of women and speak to a lot of women who are incorrectly told they can't have HRT because they've got this risk of breast cancer, but they've had their ovaries removed, so they've had an early menopause. These women have to really have HRT unless there's a big reason why they can't, because generally these women are young, and so they have this higher risk of heart disease, osteoporosis, dementia. So even if they have their ovaries removed, let's say when they're in their 30s, and they have no symptoms, they still should take HRT, certainly up until at least the age of 51, because of all the health benefits it affords. So there's lots of information to take on board. I'm sorry that I'm rambling on about it, but I hope this is just helping if I explain the reasons behind me saying yes to HRT. I do want to add that I'm not paid by any drug company, I'm not sponsored by any pharma, I'm just doing this because I want people to be given evidence-based and non-biased information. So I just want to add that as well. So let's get talking about breast cancer, because most women who have contacted me with questions have been about breast cancer and HRT. And as a lot of you know, breast cancer is very common. It affects around 1 in 7 women. That's a lot. When I was at medical school, it was 1 in 9, and then it was 1 in 8, and now it's 1 in 7. So if I just take a step back before talking about the menopause, let's look at risk factors for breast cancer. So I've already said family history. We can't change our families, but there is women who have a strong family history are more likely to have breast cancer. And then what are their reasons? Well, getting older increases our risk of any type of cancer, including breast cancer. And I find this fascinating because actually, as we get older, we're more likely to get through the menopause. So actually, women who are older and postmenopausal, not taking HRT, who have low estrogen levels, actually have a higher risk of breast cancer. And then other risk factors, a lot of it is related to our lifestyle. So actually, obesity has now overtaken smoking as the commonest cause for all types of cancer, including breast cancer. So putting on weight and being overweight or obese increases a woman's risk of developing breast cancer. And as many of you know, a lot of menopausal women put on weight because they feel tired, they feel less motivated, they often have surges in their they have depletions in sugar, so they have sugar cravings, and they have metabolic changes that occur, which means that they put on weight. So increasing weight increases risk of breast cancer. Actually, drinking alcohol more than a couple of units a night increases risk of developing breast cancer. And also poor sleep can as well, and not exercising. And a lot of menopausal women don't exercise because they feel tired, they feel they've got muscle aches, joint pains, they're not motivated. And so actually that is another reason looking at our lifestyle risk factors are very important. So 1 in 7 women in the UK will develop breast cancer. That also means that 1 in 7 women taking HRT will develop breast cancer. So taking HRT doesn't protect us from developing breast cancer, but actually it's important to know that a lot of women who take HRT and develop breast cancer, it's not due to their HRT. A lot of women are told that they have estrogen-fueled HRT, which is a terrible expression because a lot of breast cancers do not come from estrogen stimulating or fueling or causing the breast cancer. So it's very important to watch the language that's used by doctors, and a lot of doctors incorrectly feel that the estrogen is the bad part of HRT, whereas we know from studies women who take estrogen actually have a lower risk of breast cancer. So it's a lot more complicated than we realise, even that I understand, but even oncologists understand as well. So there are 55,000 new cases of breast cancer in women in the UK every year. I don't know what the worldwide figure is, but that's a heck of a lot of women who are going to go through treatments for breast cancer, who are going to probably experience some menopausal symptoms, some temporary if they're only on the drugs temporary, some more permanently if they've been forced to have a surgical menopause, and then obviously there's other cancers like I've already said. So we know also that 90% of women who are newly diagnosed with breast cancer will actually survive in the long term. So the prognosis for women who've had breast cancer and other cancers is so much better than it used to be, which is fantastic. But this means women are living longer, so they're more likely to go through a natural menopause and be menopausal for longer as well. And we know that the commonest cause of death in women from breast cancer, the women who have had breast cancer, the commonest cause of death is actually heart disease, not breast cancer, which is absolutely wonderful, but we need to look at and address ways of reducing heart disease as well. And so many women are neglected after any cancer treatment and diagnosis because there's so much energy, quite rightly, on their treatment, and then beyond their cancer, it's like they've fallen off a cliff, like they don't exist, and they can still experience symptoms, but they don't know who to turn to, they don't know who to talk to. So there are so many different ways of treating and managing their symptoms, and this is where it's really important that if any of you are struggling, especially who've had breast cancer, you receive individualised advice from a menopause specialist. And for some women, they have to see several doctors. It might be that their oncologist tells them one thing, their GP tells them something else, and then they come to a clinic like mine and we say something else. And often, as a rule of thumb, if doctors are saying different things, it's because there's no good evidence. And when there's no evidence, we're not very good as doctors dealing with uncertainty. But we have to share uncertainty with patients. So I'll share some uncertainty with you over the next few minutes. So let's look about symptoms then. So a woman, for example, who's had an estrogen receptor positive breast cancer goes to see her GP because she's developing some menopausal symptoms. What should she do? Well, when a woman's had estrogen positive receptor breast cancer, then she shouldn't be taking HRT in the first instance, and she should be looking at alternatives. Now, if a woman's had estrogen negative receptor breast cancer, increasingly specialists are thinking that women can take HRT. Again, it wouldn't really be first line, but they're more likely to be able to have HRT without any problems than women who have estrogen receptor positive breast cancer. So it's really important to look at symptoms, and a lot of women don't realise how many symptoms are related to their menopause. So there's a questionnaire on my website, menopausedoctor.co.uk. If you just put in the search engine questionnaire, then you'll see, and it's worth printing it off, downloading it, printing it off, ticking off how many symptoms, and then reflecting which symptoms are affecting you most. A lot of women think about sweats and flushes, but actually they're not usually the symptoms that affect people the worst. It's usually symptoms such as brain fog, fatigue, reduced motivation, low mood, anxiety. So a lot of treatments that are alternative to HRT focus on the flushes and sweats. And actually most women who I see in my clinic are not that bothered about their flushes and sweats. Some are really disabled with them, but a lot of people it's their brain function that's the real problem. So there are some non-hormonal treatments that help with flushes and sweats. Something like sage can be quite useful. There is a tiny bit of evidence, bit of research going on looking at folic acid, reducing the risk of hot flushes and sweats. Some people have taken evening primrose oil with success. There's a huge market, massive market for non-hormonal supplements for women, and there are some that contain substances such as red clover, black cohosh, St John's wort, but actually none of these are recommended for women who have breast cancer, and that's partly because we don't know how they work. And if they're going to stimulate the estrogen receptor, some of them contain something called phytoestrogens. If they stimulate the estrogen receptor, then it's done in a very unregulated way. And although you might say, well, these treatments are natural, I can buy them from a health shop, they come under as a health, as a food supplement. So they're not regulated, they're not licensed. We don't know what they contain. Different brands contain different amounts. So you really shouldn't be taking any of these products. But there are some complementary treatments that can be really beneficial. And for example, we know placebo has a massive effect, positive effect for women who are having menopausal symptoms. And so just talking can make a huge difference. Just seeing someone who understands, who can listen to you, to know that you're not going mad, to reassure you that you haven't developed dementia, to make you understand, help you understand that these are common symptoms and they're not related to your cancer, that your bone ache isn't due to a bone metastases, it's because of the menopause. That can be hugely reassuring for a lot of women. And then there are treatments such as acupuncture. There's some limited evidence, but when there's not good evidence, it doesn't mean these things don't work. It just means often that they haven't had the studies done. So Acupuncture can be helpful. CBT, cognitive behavioural therapy, there's a lot of work looking at that for hot flushes and night sweats, which can help, but it can also help improve your mood, make you feel more positive, help relax. So all these treatments are good because they are safe. And I have no problem about any of my patients trying any of these treatments. I worry if they're expensive and they're not working, but they certainly can be beneficial for a lot of people. Vitamin D, you may have heard me say before, we should all be taking. Vitamin D is very good for our it's a sunlight vitamin. Thankfully it's sunny day today, but it's not always. So vitamin D we should all be taking, and this is good for our bone health, but there is some evidence it can work as an anti-inflammatory. A tiny bit of evidence it reduces the risk of breast cancer in the future, but this is not great evidence. But there's no harm in taking vitamin D, and the government guidelines are we all should be taking it. And then there are women that are still really suffering with symptoms, and so there are some drugs that we prescribe that can help. Now, antidepressants are often given to women for menopausal symptoms because doctors wrongly think it will help their low mood, their anxiety, their poor sleep, but actually there's no evidence that antidepressants help to improve mood and the low mood associated with the menopause, so they shouldn't be given for that indication. We sometimes give low-dose antidepressants such as venlafaxine for women to help with their hot sweats and flushes because they can reduce that. And if a woman is depressed, it might help their mood, but they have to have clinical depression, which is quite different to the low mood associated with the perimenopause and menopause. So if your doctor is giving you antidepressants because your mood is low, then you should question whether you should be receiving that, because the guidance from NICE, the National Institute on Health and Care Excellence, are very clear that we shouldn't be giving antidepressants for menopausal symptoms because there's no evidence that they help. So low dose antidepressants can be really useful for the flushing that is associated with the menopause for women who've had an estrogen receptor positive breast cancer, and I've certainly given it to a lot of women and they've been very grateful that it's made a difference and helped. Sadly, some of these antidepressants can actually reduce libido, and if libido is low anyway, it can make it worse. And sometimes they can actually cause night sweats. How weird is that? Sometimes they help, but sometimes they can cause night sweats. So just, try it for 3 months. Usually we always say when we try something, around 3 months to try, and then if it hasn't helped, it's unlikely to. So then we need to think of alternatives. And then there are some drugs that have been used as epilepsy treatments, such as gabapentin or pregabalin. These are sometimes actually used for women who have migraines as well. But they can cause a lot of side effects, so you can be limited by the side effects. But for some women, they can help. There's another treatment called oxybutynin, which is quite an old-fashioned treatment now, used for people who have overactive bladder, urinary symptoms, and that can sometimes help with some of the vasomotor symptoms, the flushes and sweats. So there are different options to try, and it's worth going through them with your doctor to see if they help. But like I've already said, the menopause is more than just hot flushes or just a symptom. And I'm not saying just in a sort of throwaway way, because symptoms can really debilitate people. But even those women who don't have symptoms, again, I sound like a broken record. We have to think about our bones and our heart and our future health. And so when your estrogen is blocked in your body, then a lot of women find they have an increased risk of osteoporosis. There's been some women who have messaged me because they've already developed osteopenia and they're taking an aromatase inhibitor which blocks estrogen on the body. And what can they do about it? So even if they don't have symptoms, we need to be thinking as doctors about how can we help these women with their bones, with their heart? What can we do? So this is where we're thinking, what about HRT? Can women who have had an estrogen positive breast cancer in the past take it? I can't say yes or no on this screen because everyone's different and people's cancers are different, and there might be someone who's had a very aggressive cancer diagnosed last week, and there might be someone that had a very small cancer picked up in screening 20 years ago, clearly these women are very different and they need to be treated very differently. And this is where if you are developing symptoms and you want to talk more, you really need to see someone who understands the differences as well. And even in my clinic, often we liaise with a person's oncologist, their cancer specialist, and certainly all the doctors that work with me, we always discuss about patients who have had cancer, breast cancer in the past that's estrogen receptor positive. So we're all singing from the same hymn book, if you like, because there isn't any black or white. The reason there isn't is because there hasn't been enough research done into this. Now, some women have what's called DCIS, which is ductal carcinoma in situ. We see it a lot. It's picked up a lot from breast screening. And there's a debate whether this is a proper cancer or whether it's a pre-cancer, a bit like the CIN, the cervical, the CIN, which is a precursor for cervical cancer that's picked up by smears. And so we see a lot of women who have had DCIS in the past told they can't have HRT, and in fact most of those women can take HRT. I've already said some women who have estrogen receptor negative breast cancer, often they have a triple negative breast cancer, can usually take HRT because there haven't been any studies that show that taking HRT worsens in those women. Now, there were a couple of studies that some of you might have read about where they looked at giving HRT to women who've had estrogen receptor positive breast cancer. One was called the HABITS, which stands for Hormone Replacement After Breast Cancer. Is it safe? And the other one was a Stockholm Study. It was called Stockholm because I think it was done in Stockholm, so not quite such an exciting title. The Stockholm Study was randomised, which means that there were two groups of women. They were sort of literally pulled out of a hat whether they were going to take HRT or not, but it wasn't blinded. Blinded means that the doctor and the patient don't know what it is, whether they're getting a placebo or not. So that it wasn't the best study. But what happened is that they, with a habit study, they gave older types of progesterone. And if you listen to my previous talk last week about body identical HRT, you'll see there's a difference. They had 442 women in the study, and they did show that after 2 years there were more recurrences of breast cancer in women who received HRT compared to not. Now the numbers were small, there was 39 compared to 17. Now the Stockholm study actually used less progesterone, and we know that the progesterone can be associated with the risk of breast cancer. So they gave estrogen and less progesterone than in the HABIT study. Now there were a similar number, 378 women in this study, and they followed them up for longer actually. But it was stopped early because everyone was worrying about HRT, so sadly it was stopped after 4.5 years, but they showed there was no increased risk of breast cancer in women who took HRT, and the HRT with the less of the synthetic progesterone. There were only 2 deaths from breast cancer in women taking HRT who have had estrogen receptor positive breast cancer in the past, but there were 4 deaths in women who weren't taking HRT who were in the study. And in fact, this study has been followed up. The women in the study were followed up after nearly 11 years, in fact 10.8 years, and showed that there was no increased risk of death in those women who had taken HRT. So that's really reassuring. What we don't know is the role of estrogen in breast cancer. There is some people who feel that estrogen is actually a treatment for breast cancer. How weird is that? And in the past it used to be given as a treatment, and part of the way the selective estrogen receptor modulators such as tamoxifen work is they thought they can stimulate estrogen in some tissues and block estrogen in other tissues such as breast tissue. And so maybe giving HRT could be a good thing. And there is some people that oncologists say that actually giving estrogens, certainly after a few years from breast cancer diagnosis, can induce something called apoptosis, which is a programmed cell death. So it actually can kill any remaining cells, so be good. And it's so difficult. I have been reading so many studies, and I have been emailing so many oncologists who I hold in the greatest esteem, whose brains are far bigger than mine, yet they can't come to a decision because there isn't the evidence, so we don't know. There's this great book that some of you might have seen called Estrogen Matters by an oncologist called Avram Blooming. Now, he's a physician in America, and I've done a podcast with him, and he's just the most amazing man, very clever. And this book is full of lots of evidence about estrogen and how important it is. And it's certainly food for thought, and we recommend all our patients to read this before they decide about taking HRT. Interestingly, his wife and his daughter have had estrogen receptor positive breast cancer, and they decided to take HRT. So this comes down to individualisation, and about knowing the uncertainty, knowing the risks, knowing the benefits. And I've been really, I've got lots of great mentors. One of my mentors is someone called Dr. Charlotte Fleming, who's a gynecologist who specialises in the menopause in Wales. And she has been giving women who've had estrogen receptor positive breast cancer in the past HRT for many years, about 20 years or so. And she has this great quote. In fact, she's two quotes that I'm going to share with you. One of them, she says, is, "Just breathing isn't living." And I think that's really important, isn't it? When women have had a breast cancer diagnosis, it's very much about their prognosis, quite rightly so, and what benefit they'll get from each treatment. And this is really important. So most benefit seems to be, or is, from having surgery. So some women have a lumpectomy, some women will have a mastectomy, and some women will have localised radiotherapy. But the initial treatment is what's really important. And then the additional hormonal treatments are often help with this sort of icing on the cake. And if you're treating tens or hundreds of thousands of women, it can make a difference to a small number. But for you as an individual, it might not make that much difference. And there is an online tool that we use and a lot of cancer specialists use, and some of you might have heard, called the Predict Breast Cancer tool, where you basically put in your grade of tumour, whether it's estrogen receptor negative or positive, the size of the tumour, and how long ago it was, and what treatments, and it will give you this great graph as to the percentage benefit you'll get from having different treatments. And so for some women, for example, who are taking an aromatase inhibitor such as letrozole, might come and see me and say, "Look, I can't function, my joints have seized up, my brain has gone, I feel so terrible, I'm so tired." And we can look at this, and it might be that the decision is made with the oncologist to stop the aromatase inhibitor and have what's called a drug holiday. Not much of a holiday, but it will just stop. And so women can see what they're like without the drug. And some women will change from an aromatase inhibitor to tamoxifen, which doesn't block all the estrogen in the body. And they might find that makes enough difference to really improve the quality of their life. So there are simple measures, and looking at the Predict Breast Cancer tool can be really helpful, so women know that they're not going to do anything too harmful. And then some women, if they're getting side effects on tamoxifen, they might be told they have to take tamoxifen for 10 years, but actually then they might stop it sooner. And some women, we know around 1 in 3 women actually stop taking tamoxifen early because of side effects, and that's not unreasonable if it's only going to make a small difference to your life. And we have to look at the quality of a woman's life. It's not just the duration, it's the quality. The other quote that Charlotte Fleming shared at a talk she gave to us a few months ago was, "You live every day, but you only die once." I mean, I know that sounds quite awful, but actually we have to think about our lives. And actually for us as clinicians, it's really important that we look at the whole woman. We don't just label her as a cancer patient. It's looking at what symptoms are affecting her, what is really going to make a biggest difference to her quality of life. And I saw someone in my clinic not so long ago who is a hairdresser, lovely lady, and she had been diagnosed with a very small breast cancer about 15 years ago on a breast screening, and she had was on HRT at the time and was taken off it, and she had really struggled with various symptoms. She'd had chemotherapy, she'd been on tamoxifen, couldn't tolerate it, so stopped it about 5 years before she came to see me, and she had lots of symptoms and said to me, "Do you know what, Dr. Newson, I would prefer to die than carry on like this. And if I did, I think my friends would be happy because I'm such a burden to them." How sad is that? So she made the decision with reading Estrogen Matters, with thinking about the uncertainty, knowing there might be an increased risk with taking HRT of her breast cancer coming back, or there might be a benefit, we don't know. And 6 months down the line, her life has come back and she's happy, she's positive, she's enjoying her job, she's enjoying her friends, and a lot of her symptoms have improved. And she knows that her breast cancer might come back, but she's made that decision. And so this is where it's really important that women are allowed to vocalise how they feel, and with the right guidance can come to the right conclusions for them. And we work out of the NICE guidance, the National Institute of Health and Care Excellence guidelines, and they're very clear, and I've printed it out here because I wanted to read to you what they said, because I don't want you to think that I'm just trying, I'm on my own just saying these things, but they say, it is right to be involved in making decisions about your care. To make a decision, you need to know what your options are and what might happen if you don't want any treatment or care. You need to have information about the pros and cons of the options, and this must be made in a way that's easy for you to understand. Your healthcare professionals need to know what matters to you. No two people are the same, and they should listen carefully to your views and concerns. And this is really important. And they do say about HRT is that if a woman is experiencing severe menopausal symptoms on her quality of life, these may be substantial for some women whom HRT is contraindicated, which means they shouldn't really have it, but they may choose to accept a degree of risk, and that might be considered by some to outweigh the benefits of HRT. A fully informed patient should be empowered and supported to make a decision that best balances benefits to that individual when weighed against potential risks. And a lot of the risks are still uncertain because we don't have clear evidence. And it's so hard to get a trial now. There's so little research done in the menopause, which is so frustrating for people like me. So we'll never know the answer. We might do with time. But what I'm really trying to say is that if you're told, no, you can't have HRT, and you've tried the alternatives, you've tried your lifestyle, and you're really struggling, you shouldn't be struggling alone. You should really see someone. It might be a nurse, it might be a doctor, it might be your GP, it might be a different specialist, and really just be presented with the options, so then you can go forward with your life, because that's really important. Before I finish, I really wanted to talk about Sexuality Libido, because I was reading an article not long ago, and it was talking about how women are so neglected after their menopausal after their treatments for cancer. And I did a charity event. I was on a panel with a cancer charity called Stockholm, amazing charity looking helping young women who have developed cancer in the past. And in the audience, around half of these young women had freely admitted by putting up their hand that they had experienced, or they were experiencing, symptoms related to vaginal dryness and low libido. Libido is really important. It's not just about a hormone, and understandably, women who have gone through cancer treatments are far more likely to have low mood, reduced energy, reduced self-esteem. Their bodies probably change because of the treatment, and then because of the estrogen, low estrogen in their bodies, they're more likely to have symptoms such as vaginal dryness, irritation, recurrent urinary tract infections, and low libido, because libido is related to our hormones, estrogen and testosterone as well. So the treatment of this, I'm going to dedicate a whole Instagram live in 2 weeks' time about vaginal dryness and urinary symptoms related to the menopause. But I just want to say that the vast majority of women who've had any type of cancer in the past can have local treatment. Local means in the vagina treatment, including hormone treatments in the vagina. So even women who've had an estrogen receptor positive breast cancer can still usually have vaginal treatment, which includes pessaries, vaginal pessaries. There's a little gel that you can use, there's creams, there's a little ring that can be inserted. There's a new type of, well, it's new to the UK, it's been around for a while. It's called DHEA pessary, which is called prasterone, which is now available as well. There's an oral tablet, which is similar to, it's a SERM, a bit like tamoxifen, but different, called osfenifene, which is a tablet which women who've had breast cancer can take for vaginal dryness. Seems a bit strange, doesn't it, having an oral tablet for something affecting your vagina, but it can work really well. And then there are non-hormonal moisturisers and lubricants which can work really well, and we have a selection in the clinic to offer women to use as samples, but the best ones really are ones by a company called Yes, which is an organic company. There's also Silk, CYLK, and Rigel as well. There's lots you can buy over the internet or from chemists, but these can sometimes cause irritations, especially if they're scented. You have to be really careful what you're using, so it's worth looking, and often people need a combination of non-hormonal treatments with hormonal treatments. Some people think that if a woman's taking an aromatase inhibitor, such as letrozole, they shouldn't be using any estrogen, even vaginal estrogen, and the jury's out there. I know some oncologists that say no, you can still use it, or others say no, well, it won't work even if you try and use it. And so those women might be recommended to change to tamoxifen and then try using something like Vagifem. But it's very important that women know, because there's a lot of misunderstanding about vaginal estrogen, and people think it has the same risks as systemic HRT, and it doesn't. So if you have vaginal symptoms or recurrent urinary tract infections, then you should be considering some localised vaginal estrogen, regardless of whether you've had cancer in the past or not. And women who've had an estrogen receptor positive breast cancer can still usually very safely use localised estrogen. So I hope that helps, because a lot of people are still scared and wrongly being turned away. We know, I read a study recently that it said that more than 50% of women who've had breast cancer in the past have some sexual function changes, but only about 25% of their doctors are talking to them about it. So that means 75% of women are suffering, and we're very British, we don't like talking about sex, but actually sex is really important, regardless of your type of relationship you have. And I was really saddened when I was listening to these young women at this Trek Stock panel telling me that they can't have penetrative sex, they don't want to even meet a man or even the same sex. It's too distressing, and no one realised that they could have treatment. Then we sometimes offer psychosexual counselling, can be really good, because libido can be low for other reasons as well, and there are some really great people out there helping. Some of you might know someone called Sam Evans, who is nurse trained, who runs a website called Jo Devane, and she's the best person to talk to about libido and sex problems. I've done a podcast with her, and she often recommends using vibrators, which can be really good, helping externally as well. And you know, I saw someone in my clinic recently who'd had a vaginal cancer and had been traumatised by the treatment, and she just needed some help to have her sexual relationship returning. So there are lots of treatments. I'm just going to give you a few more tips for some resources. Some of you who've had breast cancer might, I know it's back to front, I'm sorry, have seen this book called The Complete Guide to Breast Cancer, How to Feel Empowered and Take Control. And it's written by Professor Tricia Greenhalgh and Dr. Liz O'Riordan, who's a surgeon and they've both had breast cancer. Tricia Greenhalgh has been on the news a lot talking about the use of masks for COVID. Amazing women, they're both really, really clever and really positive about helping women. So this is a really good read, and it does cover or touch about menopause as well. Obviously I can't do this without mentioning my book, The Good Menopause Manual. It's the concise manual written by me, but by Haynes. And then there's this sheet here. This is a booklet that I've written called Menopause and Cancer, and this is downloadable from my website. If you go to resources section under booklets, then you'll see that there's Menopause and Cancer, and then there's a few others that I've just pulled off here. There's one, Menopause and Me, a guide for younger women, because often it's younger women who are affected. And then this one, which says Lifestyle for Healthy Bones. So this is talking ways of improving your bone health, which is so important. And then I wrote this with Diane Danzebrink, who's a great friend and menopause campaigner who runs the campaign #Make Menopause Matter. She runs the website menopausesupport.co.uk, so take a look at her work. She's absolutely incredible. But we wrote this together called Menopause and Relationships, a guide for partners, because partners often are really neglected and have gone through your treatment with you, and they need to carry on helping and understand what's going on as your body changes during the menopause as well, because there isn't any quick fix. And I hope this hour has helped you to understand that there's no right or wrong, there's no one fixed treatment for everyone. There's different treatments, there's different drug treatments, there's different non-drug treatments, and even if women consider HRT, there are different doses, there are different types. We often give very low doses, for example, to women who've had estrogen positive breast cancer in the past, but my lady who I spoke about at the beginning, who'd had leukemia when she was 22, will have received a very high dose of estrogen to replace what her body would naturally be receiving. So there are so many options, but the most important thing that I really want you to learn from now is that don't suffer in silence. You don't get a medal for suffering, and if you feel you're not being listened to, go and seek someone else. Go and listen to some of the great resources that are out there. From Diane's work, there's Liz Earle is doing the most amazing work, and she's done a podcast actually with Kirsty Lang, who's had breast cancer, and I've done a podcast with her as well. And some of you might find that useful to listen to those podcasts. And she talks about the uncertainty and the decision that she made to take HRT, which isn't right for everyone, but it might be right for some of you. And for some of you listening, it might be very right for you, and you've been given the wrong information, sadly. So I hope this Instagram Live has given you some confidence to go forwards and to seek the right help, and just think about your future life as well, because it's so important. None of us know what's around the corner, so we need to take control and keep strong and keep safe these difficult times. So next week I'm going to be talking about surgical menopause and endometriosis, because